Hey, good afternoon, everyone. Welcome to today's webinar, Integrating Harm Reduction into Healthcare Facilities Serving Medicaid Members. I'm Meryl Schulman. I'm a Senior Program Officer at the Center for Healthcare Strategies, and I work on our team that thinks about how we can better integrate care for people with complex health and social needs, and I am pleased to be facilitating today's event. Today's webinar is hosted by the Center for Healthcare Strategies, or CHCS, and Anka Consulting, and it's made possible by our partners at Vital Strategies. I'd like to review a few housekeeping items before we begin. Lines are muted to limit background noise, but feel free to reach out to us via chat as needed. Today's webinar is being recorded and will be available at chcs.org following today's event. Slides will also be available on CHCS's website, and in case helpful, a link to today's slides can be found in the chat. Lastly, a survey will pop up on your screen following the webinar. We ask that you please take a moment to complete it so we can improve our work. Next slide, please. If you need real-time captioning today, it's available via the Show Captions icon at the bottom of your screen. You can click the arrow next to the button to open caption settings and adjust the font or display area. You can also view the full audio transcript by clicking Transcript at the bottom of your screen. Next slide, please. So towards the end of the webinar, we'll have adequate time for audience question and answer. So we encourage you to ask questions throughout today's event. Questions for speakers may be submitted via the Q&A icon at the bottom of your screen, and you have the option to submit those questions anonymously. For those of you who may be listening in via phone only, you're also welcome to email any questions or technical support requests to my colleague Amanda Bank at abank@chcs.org. And again, for those just joining, this webinar is being recorded and will be shared out to all who registered, and it will be also posted on CHCS's website. Next slide, please. So here's our agenda for today. As mentioned during today's webinar, we'll explore what it looks like and what it means to integrate harm reduction into clinical practice and how to financially sustain these services, specifically within healthcare facilities serving a large proportion of Medicaid beneficiaries. In a few moments, you'll hear from our funder at Vital Strategies about the importance of this work, and then I'll share more about the project that led us to today's webinar and what we've learned thus far. My colleague, Kima Taylor, will then facilitate a panel discussion where she and our panelists will explore what it means to integrate harm reduction into healthcare settings. And then, as mentioned, we'll have time for audience question and answer. So again, please submit those questions throughout, and we'll hold them for that portion of today's webinar. Next slide, please. So on this slide, you can see our learning objectives for today. In general, we hope that you walk away with a better understanding of what harm reduction looks like in practice, the different ways to integrate harm reduction into clinical practice, particularly in different settings, healthcare settings, and states. We hope you learn more about strategies to finance and sustain harm reduction services. And lastly, how healthcare organizations can meaningfully and authentically partner with community-based harm reduction programs and the value of these partnerships. Next slide, please. So before moving forward, I want to share a little bit about the Center for Healthcare Strategies. CHCS is a nonprofit based in New Jersey that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for kids and adults served by Medicaid. Since 1995, our organization has worked with every state in the nation, and we do our work in partnership with state and federal agencies, health plans or managed care organizations, healthcare providers, community-based organizations, and people who receive services, all in an effort to make healthcare work better for those who face serious barriers to well-being, like poverty and complex health and social needs. Through our work, we work to advance more effective models for care delivery, more efficient policy and program design, and across all of our programming, we focus on more equitable care and opportunities to address the obstacles that stand in the way of health equity for those facing the greatest disparities. Something else that we aim to do at CHCS is to really disseminate what we're learning to the public, and this webinar is a great example of that. Next slide, please. So I mentioned this in my earlier remarks, but this webinar is a product of a larger project made possible by Vital Strategies. Through this project, CHCS and Anka Consulting conducted an environmental scan that included a literature review and 15 key informant interviews to better understand a few things. First, what are sustainable and creative financing mechanisms for harm reduction within healthcare settings that serve Medicaid beneficiaries? Second, we were looking to better understand how partnerships between healthcare systems and organizations and community-based harm reduction programs can serve as a strategy for providing and financially sustaining harm reduction services. And lastly, we were looking to better understand opportunities for healthcare to embrace harm reduction, both in practice and philosophically. Through those key informant interviews, we spoke with a range of stakeholders, including clinicians or healthcare providers, thought leaders in this space, harm reductionists, people working at managed care plans, what have you. And all of the findings from our environmental scan will be synthesized into a brief that will come out in the late summer, and we'll highlight some of those findings through today's webinar. So before I share more about our project and what we learned, I'd like to introduce our funder and partner in this work, Dahlia Heller, who's the Vice President for Overdose Prevention Initiatives at Vital Strategies, to share a few opening remarks. Dahlia, it's all you.
Thank you, Meryl, and thank you everyone for joining us today. Vital Strategies is pleased to support this work led by the Center for Healthcare Strategies and Kima Taylor of Anka Consulting, and to be joined today by our esteemed panelists. I'm looking forward to the discussion. Just a little background on us. Vital Strategies is a global public health organization working to strengthen public health systems around the world. And in the United States, we're the lead implementation partner in the Bloomberg Overdose Prevention Initiative. As part of this, we're working intensively in 7 states, and we work there in partnership with governments and communities towards a goal to achieve an equitable and sustainable reduction in overdose deaths in those states. We do this by supporting innovative models on the ground and in policy development, and in supporting the expansion to scale of science-based policies and practices for overdose prevention. Which brings me to the topic of today's webinar. It represents something that we've had abiding interest in over the time that we've been doing this work, and is really part of a larger aim that we have to promote healthcare financing for harm reduction strategies. You've already heard a little bit about the work from CHCS and Anka Consulting on this from Meryl. We previously worked with the National Harm Reduction Coalition to develop a toolkit to support harm reduction programs to best position themselves to obtain healthcare financing for their work. And now this effort represents the flip side. Working with CHCS and Anka Consulting, we're now looking to support state governments and healthcare systems who are uniquely positioned to optimize Medicaid and healthcare financing towards the support of harm reduction strategies. So thank you for joining us today, and I'm looking forward to the discussion, and I hope you will gather and learn something to bring back to your own work. Thanks, Meryl.
Thanks so much, Dahlia. So we can go to the next slide. Awesome. So before we move forward with the panel, it's important to define what we mean by harm reduction, which at its core is a set of strategies that are designed to improve the health of patients and clients. Our team likes the definition set forth by the National Harm Reduction Coalition, which considers harm reduction to be both a way of practice and a philosophical approach to working with people who use drugs and/or alcohol. In action, this means harm reduction includes both practical strategies to reduce the negative consequences of drug use, and that harm reduction is a social justice movement that respects the rights of people who use drugs. And so people who use drugs, like all people, should be driving their care, and that should be respected by the healthcare community. I'll note that the National Harm Reduction Coalition has outlined 8 principles of harm reduction that can be used to guide harm reduction activities. If you haven't seen those, I highly recommend checking those out. They're linked, they're on their website, and that's linked at the bottom of the screen that you'll receive after the webinar. So harm reduction also occurs on a continuum. And there are often misconceptions about harm reduction. One of those misconceptions is that it encourages or enables drug use, and we know that that's not the case. Harm reduction accepts that some people use drugs and asks providers to provide non-judgmental and non-punitive care, while also being realistic about the harms associated with drug use. As such, providers might offer harm reduction strategies and services such as guidance on safer use, naloxone, xylazine, or fentanyl test strips, and any connections to physical and behavioral healthcare services that a patient may need or desire. But ultimately, people have the right to choose what services are for them and what they engage in. And during our panel discussion today, you'll hear more from our panelists, all of whom are healthcare clinicians, about what harm reduction actually looks like in action. I should add too that overdose deaths and non-fatal overdoses declined last year. However, there are still too many people that are dying from drugs in this country, and disparities in access to high quality addiction treatment continue to persist. Researchers speculate that there are a variety of factors contributing to this decline, one of which is harm reduction, notably increased access to naloxone. Next slide, please. So I'll conclude this portion of the webinar by sharing a few early themes from our environmental scan. This is not an exhaustive list, but a few thematic highlights from what we learned. The first is that harm reduction is relevant to all providers, including those who don't typically work with people who use drugs and alcohol. First of all, interviewees underscored that healthcare providers and people in general often use a harm reduction approach for other diseases. They just call it something different. For example, certain vaccines and condoms are a form of harm reduction to protect against sexually transmitted infections. Sunscreen is also a form of harm reduction, protecting the skin from the sun. Harm reduction for substance use is also relevant to all providers and in all care settings. Because of the stigma related to substance use, many people may not disclose their use. And so providing harm reduction as a form of anticipatory guidance not only can improve health outcomes, but if done in a way that is non-judgmental, it can actually help the provider earn the trust of the client or patient so they're just willing to disclose about their use. I mentioned this on the previous slide, but we also heard from interviewees that harm reduction itself occurs on a continuum. And adopting a culture of harm reduction can also occur on a continuum and may not mean that you need to completely overhaul your current approach to the way you provide care or the way that you do your work. We learned from those that we spoke with that there are often lower lift ways to integrate harm reduction into practice, like changing the way that you ask questions to be less judgmental. And another example would be co-prescribing naloxone whenever an opioid medication is prescribed, whether for pain or for medications for addiction treatment. The latter practice is often reimbursable by most insurers. Harm reduction services may also include access to low barrier medications for opioid, nicotine, or alcohol use disorder, most of which are reimbursable but are often difficult to access due to stigma and restrictions on who or where these medications can be prescribed. We also learned from interviewees about the value of telehealth. Telehealth, another reimbursable service, can be an important tool in meeting the needs of people who use drugs, and it can also expand access to culturally and linguistically appropriate services, particularly in environments where there may not be providers who look like or speak the primary language of the populations that they serve. Consistently, interviewees share that there are an array of funding streams that they leverage to support their harm reduction work. This includes Medicaid reimbursement, federal and state behavioral health grants, opioid settlement funds, among others. We also heard from interviewees about the importance of engaging leadership in harm reduction work, not just to explore funding opportunities, but also to make sure that harm reduction becomes embedded in the culture of an organization. Interviewees underscored that leadership buy-in in general is key to investing in organizational training efforts and education. And like any organizational change effort, it's important to consider what matters to your leadership when you're engaging them, and then tailoring your ask accordingly. Another theme that emerged through our key informant interviews was around partnering with community-based harm reduction providers. Community-based harm reduction providers have been doing this work for a long time. They have deep expertise, deep roots in the community served. And these harm reduction services that they offer have historically been grant funded at varying levels of sustainability. And so there's an opportunity to sustainably fund these services and bring them more into the continuum of care offered by providers in traditional healthcare settings. As such, healthcare organizations should connect with and fund those community programs and build meaningful and authentic relationships to help inform their work related to harm reduction. And lastly, interviewees noted that harm reduction efforts should be informed and led by the community served. And so that means that what works in one community or for one person might be different than what works for another community and for another individual. And we should be mindful of that when we're doing this work. So again, more to come in a brief that will be coming out later in the summer. But those are some early themes that emerged from our scan, and you'll hear more during the panel discussion. Next slide, please. So now I am pleased to turn it over to our partner in this work, Kima Joy-Taylor, to facilitate our panel discussion. Kima is a pediatrician by training. She has committed her career to working with people and advocating for people who use drugs, including pregnant and parenting people. Kima, it's all you.
Thank you, Meryl. I'm going to ask the panelists to come on. I really want to thank everyone for joining us today. Dahlia was on at the beginning of the talk, and she gave her foundation credentials, but really Dahlia and I have been working on this piece of trying to get Medicaid to cover harm reduction for many, many, many years. This is a part of my white whale, and we worked on the project around how to think about including this in the health system. And as we know, it's hard to include in the health system if people don't want it in the health system, but also you really need financing for that to happen. And that's part of why we embarked on this project. It's one thing for harm reduction programs to create their value proposition for providing sustainable services. It doesn't work if no one's buying it. And so, as Dahlia said, this is kind of the other half of that piece. And through our discussions and through our interviews, we met some amazing people who have been in this space and are starting to do some of both the cultural work of changing cultures in order to include harm reduction, as well as the financing work. And so I'd like to introduce them in no particular order. But first is Kate Gleason Beck. Well, actually, you have it here, but Bachman, who's the Senior Nurse Manager of Clinical Quality Improvement for the National Healthcare for the Homeless Council. Samuel Wyobe, who's addiction medicine physician, I will slow down, for Piedmont Columbus Regional Midtown Family Medical Center in Georgia. and Stuart Fisk, who's the manager opioid settlement funds, Office of Behavioral Health of Allegheny County Department of Human Services in Pennsylvania. These are mere titles. It says nothing of actually the richness of background that each of these panelists have. And some of that's going to come out in our discussion today. So I will start with the first question. And as I said, this conversation, though not exclusively about financing, is about financing. And that's where we're going to start. It's this idea of we truly do harm reduction in all other parts of medicine. And often it's called secondary prevention, and often it is finance. And so we're seeking to have that same infrastructure for people who use substances around their substance use. And so I'm going to ask the panel, do you have ideas on how healthcare systems can sustainably and reliably fund equitable access to and outcomes from harm reduction services they create? And not just naloxone, though that often comes up and it's had its own journey in a positive way, but really thinking broadly about engagement services, syringes, low barrier medications, contingency management, some of these other services. How can the healthcare systems sustainably, and I keep pressing that because it really is that sustainable funding that's going to be necessary to ingrain it within the culture of medicine, but how can they think about doing some of this? And I'm going to start with Stuart.
So I've spent a lot of years and a lot of time thinking about this and have been relatively successful because of the work that myself and a lot of other really smart people have done, particularly here in Pittsburgh at Allegheny Health Network, which is one of our big health systems here. I've worked clinically, mostly in HIV for the last 30 years. And I started as a hospice nurse in downtown San Francisco in single room occupancy hotels in the Tenderloin. Just out of nursing school, where they taught me almost nothing about sexual behavior and drugs, but they did teach me how to inject drugs safely. I was working a lot with patients who were dying of AIDS and had very poor immune system function. We're continuing to inject drugs and really consequently having really terrible wounds. So it occurred to myself and my colleagues that we should teach people to inject drugs more safely. So this was probably 1992. And I was very firm that we needed to document the work. And so this was the first lesson that I had, was make sure that you document your work where it's appropriate. We actually ended up getting paid as nurses by Medicaid to do safer injection teaching because we documented it as health promotion and safety. And they either never read our notes or they secretly agreed with us. I don't know which one, but we never got dinged for that. So that was a lesson to me that if you want to integrate, you need to integrate and you need to practice and you need to be open and honest about it. Same thing when I moved here to Pittsburgh in the mid-90s. There was an illegal needle exchange program. As a clinician, I joined them. I openly fought for legalization of needle exchange and the integration of needle exchange, kind of with health providers and health systems, and said, we're not going to stop doing it until you make us legal. And they eventually got tired and they did. So there's a persistence that's important in this work. And there's a level of honesty and openness and not hiding the work. So I just want to start there. One of the things that after moving to Pittsburgh was helping to develop a Ryan White clinic. And it was very clear from the beginning that we were a harm reduction based clinic, and that was built into our policies and procedures. It was built into how we treated people who use drugs. We openly and actively recruited and welcomed people who use drugs into our clinic, and built policies and procedures around supporting people who use drugs so that they could access HIV medication and do much better. So consequently, our clinical outcomes were really good. And that shows up with insurance companies and with health systems. And we actually were one of the highest performing clinics in the health system by, the mid-20s. And they said, could you help us design primary care in this way so that we can help everybody? So we ended up creating a whole center, which I don't want to go on about right now, but I'll kind of add in there. But we built a center that was, again, built structurally on the principles of harm reduction with a leadership that absolutely deeply understood what harm reduction was. And we did it very practically. And most of those services are now funded through the health system and through the insurance companies.
Awesome. Thank you. Some key lessons in there. Kate, we're going to turn to you.
Yeah, I second all of that. And I think, Stuart really touched on this piece, which is so huge, just incorporating harm reduction practices and approaches into all of the care that we do. Many of these things we're already doing and they are billable. They are part of our patient visit, but we really need to work with our kind of teams as a whole to think about how our multidisciplinary teams can be a part of a harm reduction approach and can kind of understand what it is. So for example, like when people come in, how do we make it routine that we're asking folks about substance use, that we're asking folks about if they're concerned about withdrawal, if we're sending someone into the hospital, that we know to ask, do you think you're going to need withdrawal support? And do you need help with that? How do we use our behavioral health team, who's already part of the health center space, as a key part of this support system, so that it's not all on just the provider who's seeing the person for primary care, but we do have these elements in most health centers to be able to kind of pull everybody in. And so a piece of this is really just understanding it as a concept. Like, what does this mean to be doing harm reduction based care? We're likely already doing it. We're doing it in multiple areas. But how can we kind of frame it in a way that makes it more consistent? And then I do think the other piece is documentation. Unfortunately, we're not being billed for all of the pieces that we're not able to bill for all of the pieces that we're doing. But I agree, the more that we show what we're doing, for example, if we are spending a huge amount of time on wound care for folks who are coming in who are using substances, how can we document and then demonstrate that we have a need for additional funding in this area, that this should be billed differently? So those pieces are huge. So I think that's what I'll say for now. But I think we're doing it. We just have to kind of package it in a way and kind of let our folks know how to kind of proceed.
Awesome. And last but certainly not least, Sam.
Yeah. Thanks everyone. I think maybe I'll go from a different direction, which would probably be saying certain regions of the country we haven't even picked up the pace. And that is fact. I'm lucky enough to have experienced being in a geographical region where things are done a little bit more better. So you can talk about billing, you can talk about like documenting properly. But I don't want to speak for every other person's experiences. But down south, a lot of the heavy lifting is done by community partners. So I want to first start out this conversation by saying thank you to all the folks who are doing the good work of harm reduction in the community. Because in certain regions of this country, I'm telling you, 99% is done by those community partners outside of medicine, outside of the healthcare system. And I think for that aspect of the country, I think the conversation would start off from even something more rudimentary, which is having conversations about how do we have the conversation. This involves like tact. As Stuart said, I love something he said in the last meeting we had, which was health promotion. I moved down south and I've had to change a lot of my language, not because I want to betray harm reduction, but it's the only way I can get people to listen to me. So, I mean, talking about things like infection prevention, right? Syringe exchange is infection prevention. People listen to you when you say infection prevention, but when I say syringe exchange, they look at you like, oh my God, you're trying to enable people using drugs. So I believe getting to a point where we have sustainable funding would first of all mean that we have a lot of work to do in making people understand what we are doing and maybe break away from our silos. Like we know the evidence, we know the right thing to do for this population, but unfortunately, there are people who do not have the information we have. So I don't get mad anymore. I think the first thing for me has in trying to integrate this and make it more sustainable is changing the language around it and making people more involved in the care for this population. I mean, in terms of, oh, everyone in the community wants infection prevention, or everyone in the community wants to make sure that police officers are safe, or EMS is safe when they go to respond to an overdose. And these are things that people kind of, I believe, begin to get interested in what you're saying. Now, talking about funding, sometimes it's easier. I found it easier to kind of, I don't know for what the stigma around, especially opioid use disorder, means sometimes it's easier to get people to understand harm reduction starting off from alcohol use. For instance, we talk about peers, right? We talk about peer-based coaching. That is in a way already done with alcohol use, right? But when you say the same thing for people who use opioids, it becomes a little bit of a difficulty. So I usually start my conversations from the front of alcohol or some other substance that some people might feel comfortable with, and then make them realize substances are the same. So I think my starting point would be even getting to a point where we can get Medicaid or get funding for a long time would involve changing thought patterns. I guess we'll talk some more on that.
Awesome. And I think that what you're saying, and it's going to lead me to another question, is very much in line with what Meryl first introduced. There's the services and the practices, but there's also the movement, right? How to get people to understand and even accept the services before you can think about providing them. And so that's incredibly important. And it moves me to another question. I did warn the panelists I was going to go off not necessarily in order, because it came up in the Q&A, which is also I wanted to bring it up. We are currently entering possibly a period of scarcity, right? With SAMHSA cuts, expected Medicaid and other cuts. And so thinking about recommendations for folks involved in harm reduction at this moment, and part of it, Samuel, by what you're saying, like you're talking to people, leading with alcohol, using different language, that actually doesn't cost money, right? That's something you can do. I mean, not to devalue your time, because that is important, but it's not a billable service, right? And so that's something that can be done in times of scarcity. But having said that, we also want people to keep living. So we'd like the actual services as well to continue through Medicaid. And I do want to say, as we're expecting Medicaid cuts, because there will still be people on Medicaid who need these services. And there will still be other people in the healthcare systems who are not on Medicaid who need these services and need health systems to understand. So it's not we really cannot abandon our work or efforts moving forward. And I want to hear some of your thoughts around how do we think about what harm reduction services we want to provide now, even in the face of scarcity, and how we want to build our infrastructure so that we're ready when scarcity recedes. Who would like to go first? Bless you, Samuel.
I think starting from the SSPs, right? And the reason why I say SSPs are so important is they kind of are the melting pots for a lot of services, right? It might be someone's first ability to get linked to treatment if that is what they want, but it also helps as an infection prevention tool. It also helps as a peer coaching environment for those who are in a physical space. So if I was going to prioritize especially one service that has been uniquely placed to help and have broader impact, is actually SSPs, just because of the impact they have on overall care for folks.
Awesome. I totally agree. What Stuart?
Yeah, I agree. I think SSPs are really important for a couple of reasons. One, they are really important in terms of infection prevention, but they're also really a great way to kind of consolidate and integrate a lot of different services in a way that isn't always visible. And I just would say, as healthcare providers, I think there's some element of the work that we've always done that's been harm reduction, and there's always been times when we've kind of had to submarine that somewhat, and that's okay. Like, if we can't say inclusion, diversity, and equity, we just need to do it. Right? The actions that we perform as healthcare providers, as policy people, as activists are much more important than the language. We can bring the language back when times get better. We can also, in certain circumstances, use the language to our effect as a tool of opposition. So you kind of got to like figure out how to do that, right? But I think a lot of us are smart enough to do that. One of the things that we did here was so needle exchange is illegal in Pennsylvania, except in Allegheny County, Pittsburgh, and in Philadelphia. That's basically true. And so we serve a lot of people from surrounding counties where needle exchange is not legal. We're, don't tell our health department we do that, right? But the fact is, county borders are pretty permeable. So we partnered at Allegheny Health Network, we partnered with Prevention Point, the syringe service program, to bring a medical van to be co-located and in fact integrated into the work of the SSP, and started delivering medical services like wound care, low barrier buprenorphine access, a lot of, trying to address a lot of social determinants of health. And what we understood and what we were able to build was the fact that Allegheny Health Network could bill Medicaid for those services. And so it became self-funding in a way that it never was when we were just sort of like being hired, thank you, Vital Strategies, by the needle exchange program to do the work. We couldn't bill when we did it that way. But if we as a Medicaid provider system showed up and did it 15 feet away from the needle exchange van, we could bill for it. And because we have centers of excellence that get from Medicaid gets a per member per month bundled payment when the center of excellence sees somebody with opioid use disorder, it becomes even more sustainable. So there's ways of partnering and bundling services with those community-based organizations that is great. And we have that built, and we can continue to do that, right? And it actually generates enough money that we can support, to some degree, people who are uninsured. So that's the thing about building the structures into the system that can't be easily eradicated when the funding shifts or the politics shift. The structures are there. They have to actually come in and knock them down, which is harder for them to do. So.
Thank you. Kate.
Yeah, I think I agree with all that. And I think those partnerships are so key, and to be able to integrate services. And I'm just thinking of a few examples that I also have been a part of or have been aware of across the country. So there is a program currently in Knoxville, Tennessee, that has partnered their county health department with their probation services office. They are doing harm reduction. They are not calling it harm reduction, but they have set up a program for folks who are engaged with the health department and engaged with probation. They have a release of information between the two, and they're able to coordinate services. They're preventing people violating probation, going back into the carceral system, and they're providing health services to folks. This is directly related to an HIV outbreak that they've had in the area. So they have really been able to kind of innovate and have done this kind of partnership that I really haven't seen working before, where folks are really getting this kind of wraparound care through probation, and then where they're getting their healthcare services, substance use services through the county. So those type of partnerships, I think, are so vital, just as Stuart said, to like setting up this infrastructure so that it's in place. If things start to get rocky, these things are already happening. In the same area, they used opioid settlement funding to have CHWs go into the jail system to work with people, to help them if they're interested in getting on medications for opioid use disorder, to help with overdose prevention risk, and to do HIV testing because they're having an outbreak right now. So that has also been a super innovative model. And I'm thinking too to Arizona, where one of the health centers down there has done some like co-funding with their health center using just their like PPS rate that they get for their federally qualified health center, but also some funding with the hospital to place community health worker staff directly in the emergency room to be helping coordinate people getting into primary care services, folks who are coming in with overdose, making sure that they get connected with medications for opioid use disorder if they're interested. So they have done this like co-location of services that has really helped people get connected to primary care. And the final thing I'll say about that is just to remind everybody that substance use services can happen in primary care. You know, sometimes they're happening elsewhere, but as primary care providers, we also can be supporting people around Suboxone prescribing in particular. But many primary care offices are also doing contingency management pilots, and they're working with alcohol use disorder. You know, all these things can happen in-house in primary care. So that's so key to all these partnerships too, I think.
Awesome. And I just want to pull out a couple things that you all are talking about. First of all, I know that we're going fast, but I want you all to try and listen in when you go back and listen to the recording on all the payment sources they mentioned. PPS rate, you know, that's for community health centers. Stuart talked about bundled payments. We've talked about 340B in the past, and really, and you know, as we build the infrastructure, these partnerships where some can bill when they're co-located, there are ways to sustainably fund and finance this work. And that is a really important piece. And as Stuart said, it's often harder to pull something down once you've created that infrastructure. And I will also say that often it's the funding. I mean, just being honest, if folks are seeing a patient, you know, every 15 minutes, every 7.5 minutes, you actually do need reimbursement for many of these services. And so thinking through these strategies often is a way to get some of the primary care providers and others on board. But I saw Stuart come off mic, so I'm going to pass it to him real quick.
Yeah, I did want to just go back and touch on 340B funding, because through the Ryan White Clinic that we had here, we were able to generate quite a bit of 340B, what they euphemistically call savings, which is actually revenue. And I don't know that enough people are really, one, maximizing 340B savings in their clinics. And two, if they're using them in a way that we really used it a lot, which is almost like venture capital. Like we would go to the healthcare system because we had excess revenue and we said, we think this is a good idea. And a lot of times it was a stone cold harm reduction intervention. We didn't necessarily use that language, but we will fund it, we'll set it up, we'll fund it, we'll follow the outcomes, and we'll show you that if it works and saves money, you'll buy it back. You'll buy the program from us. And that's how we were really successful. So really, Mac, getting money in, if it's grant money, if it's opioid settlement funds, if it's 340B dollars, whatever it is, if you got a pile of cash sitting there, think of something you want to do, build it, and then sell it. And it doesn't always work, but it does sometimes, because then you've got tangible evidence that what you've done is an effective intervention that actually helps the bottom line of the health system or the payer. Because sometimes the payers, you know, they have conflicting interests with than the provider does. And sometimes you can go to the payer and say, listen, you know, this is not necessarily something your provider system wants to hear, but we think you can save money if we do this. And sometimes they'll then fund it or create some type of payment structure that allows us to sustain it. We do not have a rational healthcare system. We don't have a national healthcare system, but we certainly don't have a rational one. And irrational systems can be manipulated if you understand them.
And yes. And so folks can see why we have this group on the phone, and people who know me know that I'm a nerd for financing and how you can move it. And I think Stuart's bringing up something really important is our healthcare system is not only not rational, but most people don't understand it to manipulate it. And so that's an important piece too, understanding the leverage points. The providers are different than the payers. And people often say, well, you know, the providers are making money XYZ. Often they're salaried, so they're not. Right. So that leverage point is missing. And so it is sometimes going to the payer and looking at some of those other places. And I would also like to pull out in this conversation the community aspect. And every single person has mentioned the importance of community and some of those partnerships. I do want to be honest and say you clearly have a panel of the true believers, right? I am not naive. Like I said, this has been a long-term quest, all of this long-term quest. But it's not just that certain states are great at it and certain states aren't. no one has really embraced drug users across the country for ages. We have a really hostile attitude towards people who use drugs. And so regardless of whether you're red, blue, purple, green state, you're going to need to be able to articulate some of the arguments that Samuel talked about, some of the financing mechanisms that Stuart's talking about, to really get people to integrate this. So with that, I'm going to get to the next question. And recognizing that harm reduction is practiced in all other areas of chronic disease, be it hypertension, diabetes, autoimmune diseases, we often call it secondary prevention. But it starts with people's realities, what they're doing, and intervenes with practices that you can use to keep them as healthy as possible, even with the disease. So example, giving someone additional insulin if they go to a birthday party and eat a bunch of cake, right? We do this. But in harm reduction, it's often vilified as an enabler. So syringics exchanges are enablers, clean pipes are enablers. How can we think about how can healthcare providers and administrators start to change the narrative and include substance use harm reduction in clinical and financing structures in the same way harm reduction is included for others? And this is getting a little more towards that, not just the practices, but the philosophy. But are there, because we want people to go home with something, are there one or two concrete strategies or action steps that you used or you can think of that people can take home to start thinking about really this integration in a way that makes it sustainable? And I just use naloxone as an example, or even medications for opioid use disorder, right? When we were younger, methadone and bupe were harm reduction. People were like, oh, those are enablers. It's the worst thing ever. Now people admit it's the gold standard and it's paid for. Similarly with naloxone, originally that was discouraged and now it's paid for. So are there lessons we can learn about that integration, ultimately financial sustainability? And now you would be hard pressed to get people to be like, you should not pay for buprenorphine, right? So to get that kind of, that's what you do, attitude into the financing system. I'm not naive enough to believe that everyone then provides it, but at least it's being financed, right? Who would like to go first? One or two strategies you want to give folks from your experience?
All right. Oh, go ahead, Sam.
All right.
We all unmuted at the same time.
I think the first thing I've come to realize, I don't know if this is true across the country, is that it will be so difficult to integrate, harm reduction as a whole in hospital systems until there are billing pathways. Unfortunately, the hospital systems are run by C-suites, not medical providers. A lot of things that they do are pluses and minuses on a balance sheet. Might have some luck with nonprofit hospitals, and some nonprofit hospitals might need off-ramps. What I mean by off-ramps include that they might not necessarily want to take on the services themselves, but could fund it as part of community health benefits, right? So if you have a nonprofit hospital in your system, one of the things you try to figure out is if there's any community-based studies that show that substance use is a problem, which I believe it is in most communities in America, and then take it up to the nonprofit, and they would willingly be able to fund community-based outreach. They might even fund mobile clinics. So that's one way I think I've been able to navigate that, is figuring out what your hospital system is about. If it's a for-profit hospital system, very unlikely that they would engage completely in harm reduction, just because, except they can bill for services, they probably wouldn't even like it, unfortunately. So I think that's my one takeaway. I think the other thing too is something I had already talked about before, which is tact in bringing this in. An example is contingency management. It's actually a shame that the one thing that is evidence-based for stimulant use is the one thing that is not covered. I mean, that is unfortunate. And I think one of the ways might be either converting that to saying contingency management behavioral therapy and getting it billed as a billable psychotherapy code or something like that. That might be the future advocacy that we can get around CM, which is something that I believe is necessary. And I think the last piece is, I will come back to this always, is peer-based. Understanding, helping hospital systems or clinical systems understand the role of peers in recovery and in helping folks who use drugs. I know right now you can bill Medicaid in some states. In most states, unfortunately, it's not like that. So the question is, I do believe if there's an opportunity to get peers in fully credentialed, there might be an opportunity for hospital systems to get them in since they can bill for those services.
Thank you. It's like, yeah, the contingency management. It's, my daughter always says, make it make sense. And what we're doing does not make sense, right? It's a shame. And I do want you to note for all the speakers, the creativity. It's like, well, let's call contingency management behavioral therapy. And I always said, don't tell me what you can't do, figure out a way to get it done. So I like the way that you're really thinking, Samuel. Who wants to go next? Yo, I will call on you since you came off at me at the same time. Kate.
Thank you. I am thinking of two things about this, and one of them I think is just having, like, bringing it way, way down to like the individual and kind of community and even like health center level of just having conversations with patients and providers about fear that they have, discomfort that they have around this. Because even though, we're doing this work in primary care, primary care providers can prescribe buprenorphine, for example, there's still a lot of fear of working with people who use drugs. People are afraid about, what it's going to be like to maintain boundaries, and are people going to get mad, and is it too intense, and I haven't done this before. It feels like stepping into a new realm, even though we are kind of trying to say, and I think it's true, this is part of primary care. This is part of all of our communities. People use substances, they need support. It impacts all their health, just as their diet impacts all their health. We need to just figure out a way to do this. But there is a lot of fear. And I find that having conversations and just understanding, and even helping someone else to understand, almost through like a motivational interviewing conversation, like, what is the fear? What is the basis of their fear? What are they afraid is going to happen if they begin prescribing buprenorphine, for example? Or what are they afraid of in implementing a pilot program for contingency management? And I found those can be very rich conversations. You can find out a lot. And there are ways to support people around those fears, often just through education and understanding that we are already doing this in other ways. We would not take insulin away from someone who's diabetic if they're not having improvement and say they're not committed to it or they just don't want it enough. Like, we would not do that. And so why are we doing this to folks who are using drugs, and instead of increasing services when they're struggling, removing all supports? And so sometimes those conversations, they just go a long way. And I think very much related to that, my other tip would be putting in place protocols that help give boundaries to providers, because it can feel very scary to step into the space that they haven't been in. And having like an algorithm to understand, like, how does it work if someone is getting buprenorphine and they're coming back and there's none in their system for, this many times, or, they're positive for fentanyl, but they're also trying to use the bupe. Like, how do I manage all of this in a way that's patient-centered, but also doesn't feel like we're working in chaos? And so an example of that, I'm in Philadelphia, that's where I'm based, a program that was kind of struggling with this sort of Wild West system where everybody was doing something different and patients were getting mad. They were seeing a different provider each time, and each provider was approaching it differently. And like, it was kind of a mess. It helped everybody so much, the patients and the providers, to have this clear protocol of like, this is how we do it. This is how we support you. If you're struggling, we'll help you get into other services, to more supportive spaces. And that has also worked in Philadelphia in the inpatient setting around order sets for people who come in to the hospital and are using fentanyl. We have a very, very high fentanyl use in Philadelphia, so people need a lot of withdrawal support. If they're having pain issues, they need a lot of pain management, and it's very frightening for providers to give those doses. And so Temple University Hospital here has developed an order set that can go in for someone, and it helps the providers figure that out. They're not making the decision alone. They have this order set for pain management for folks who are coming in using fentanyl, and it has made a huge difference in terms of people getting their pain managed. They're more likely to stay in the hospital, and those are harm reduction, life-saving interventions. People also then get maintained on their kind of dose that they're at. And of course, if they want to transition to methadone or something else, they can, but they're then not leaving the hospital at very high risk for overdose because they have gone through withdrawal in the hospital. So those are strategies that I have really seen work.
That is awesome. And I just want to go back to the community conversations. I love that. And there are strategies people can use to do that, right? There used to be community-oriented primary care. There's all these strategies for people who are a little intrepid in starting. And I think FQHCs and healthcare fulfillment's a little unique in that you have a board with clients. And so you could even go through it that way. But I do want to stress, and I know that you guys do this, but for others, we often focus only on people in recovery. And it's important when you're putting strategies together to talk to people who are currently using, right? So, and help you build a system that people actually want to engage with. Even if they keep using, they need to be able to come in for their diabetes or for their foot pain. And so not like really trying to get a diverse set, and all of the definitions diverse set of clients in this conversation you're talking to, which I know that you all often do. And Stuart kind of blew by it. But again, in his work, really integrating the people who are using the services so you know what services people want to use. But I do love the protocols and giving boundaries. And some sites, you know, there's also then, if you get out of your depth, you can have a hotline you can call for further questions, or you can ask the senior practitioner. But those baseline protocols just make it so much easier to start, right? I'm going to pass it to Stuart.
Oh my gosh. Yeah, everybody's like saying some really important stuff here. So it's great. Yeah, so as a former primary care provider for people with HIV who use drugs and had serious mental illness and were unhoused, primary care is death by 1,000 simple things. And if you have an integrated multidisciplinary team with protocols that guide people through the work, it is much more likely to happen, because asking somebody to do one more simple thing is really hard sometimes. So you have to help, and you can't lay this all at the provider's feet. You have to build teams, peers, nurses, social workers, behavioral health consultants. Some of those people can bill, some can't. So that's important. And there's also really think about the difference between integration and co-location. Integration is always better than co-location. And I want to end just with a story about talking to people, because sometimes, you know, you don't understand what people don't know, right? So I was a number of years ago was talking with people in our associated payer system, Highmark, and they were really kind of like, they really wanted an opioid overdose death dashboard. They wanted to be able to know how many of their members had died of opioid overdose. And we just worked on this for like way too long. And I finally said, why do you want to know this? And they looked at me like I was crazy. And I said, well, what else would we want to know? And I said, how about hepatitis C infections? And how about infectious endocarditis? Do you understand how much money you lose on those two things when you could be preventing them? And you could see the light kind of go off. And I said, and besides, and they really looked at me like I was horrible, and I'm not a horrible person, but I said, look, for you guys, a dead member is revenue neutral, right? You're not paying out, they're not paying in. You need to look at where you're losing money and at the same time save people's lives. So that began a whole conversation about infectious endocarditis, why we should be teaching safer drug injection to people while they're in the hospital, why we should be building a medical respite center where those people can be discharged to, get out of the hospital, which costs the systems a ton of money, get them into a medical respite program where they're paying, you know, a per bed, per diem rate to keep a bed open for someone coming out of their hospital, and they can stay there for 6 weeks to get IV antibiotics if that's what they need. So it just, so the realization that they don't always understand, particularly the people that run the systems, because they're not clinicians often. So we really have to kind of dig in and really like ask hard questions and say difficult things sometimes to get people to understand. The other thing, and I'll end, was a conversation I had with our cardiovascular surgeons when we said we want to move people out of the hospital who are still actively using drugs with central lines in them to deliver IV antibiotics. And they were just freaked out. And I said, what are you concerned about? And they said, we're concerned that these people are just going to die of overdose at like astronomical rates, and we're going to be sued. And I said, I went and I checked. There's no case law of a physician being sued if somebody uses a central line inappropriately after they've been educated about how to use it. So educate them how to use it. put them in a place where somebody can come deliver the drug safely to them, and you'll be fine. And I said, besides, what's the difference between injecting fentanyl into my antecubital vein in my left arm and into a PICC line in my right arm? What's the time difference between getting that fentanyl to the brain and an overdose? I said, you're a cardiovascular surgeon. You understand this. And they were like, yeah, there's no difference, is there? I said, no, there's not. So give them naloxone. So that sometimes it's just those conversations, right? And then you end up with these systems that get built because people now understand that they can save lives and save money.
Thank you. And we're about to wrap up and pass it back to Meryl for questions. But I do want to center the fact that through this conversation, the theme that kept coming out is we're talking about whole people. This conversation is about substance use financing, but that is a mere piece of why this integration is important. No human is just substance use, right? It's how you provide all of the services people need, want, deserve as their right, in order to improve health and outcomes in partnership with them and as they define it. And so some of this, part of the part that Stuart was talking about was how you think about providing, the cardiology pieces. Samuel was talking not just about the peers, but the overall, you're in the hospital, what do you do? But at the end of the day, it's not, substance use has been ignored because we vilify often people who use drugs. We have systems set up that were punitive, that were not helpful in terms of their well-being. And now what we're really trying to create is a holistic system that includes substance use services as a health concern, that treats the entire human being for all their intersections and complexities that exist with their health and well-being, and helping them to be as healthy as possible. And underpinning that is there is money. All of the people who spoke today talked about the different resources and financing structures that they tapped in order for that to be a reality. And underlying that is, and I'm going to repeat it, my mom said, don't tell me what you can't do, figure out a way to get it done. And the people that you see on the screen are like, how do we get it done? Because we know people have the right to holistic health care and well-being, and that's what we're going to provide. And many of those, having that overarching goal often helps you think of the language, the different strategies needed, the different people you need to talk to, inclusive of people who are using and have used and in recovery, and really to get to the place where, as Samuel brought up, communities are different. So what does your community need? And that comes with listening, that comes with caring, and it comes with sheer patience and determination, even in times of scarcity like we might be facing now. And so I'll just end with saying, we can do this, people. This is my white whale, and we are going to do it, and we're going to get there because people deserve it. And so I'm going to pass it to Meryl.
Thanks, Kima. We can actually drop the slides, and thank you, Stuart, Kate, and Samuel. So we have time for audience Q&A, no surprise. I don't know if you all can see this, but you're getting a lot of love from the audience. They keep sending emojis, and we also have a number of questions. So I'm just going to try and trickle through as many as possible. There's one question from an attendee, and I'll just read it because it's a little bit complicated. So this attendee is saying that there was a bill introduced this session in Oregon for 1,000-foot setback from schools and child care facilities for SSPs or syringe services programs. The bill also included an unfunded mandate for local public health agencies to convene a community advisory board to provide space for community members to share their concerns regarding these syringe service programs, and in theory, garner community support for them. They're wondering, in preparation for future legislative sessions, do you have any resources or insights to share on this topic? I assume they mean related to syringe services programs and where they're located in the community, and related to like NIMBYism and community buy-in. And I'm curious if Stuart, Samuel, or Kate, this is something that you all have encountered in your work at all.
Yeah, so I'll say that when the needle exchange was first legalized in 2002 in Allegheny County, we were handed a set of regulatory standards that allowed us to basically open a syringe service program in the entire city of Pittsburgh in the middle of a graveyard. That was the only place that was far enough away from all the stuff they wanted us to be away from. And so we just had to fight to get those regulations changed. I would say getting legislation introduced that has alternative processes for getting community input. You know, we have been able, it makes it difficult, but we have been able to work through those community listening sessions and gotten into some of the highest risk areas, at least in the city of Pittsburgh, and now moving out into the county and more rural areas by really learning how to talk to people about what we're doing. We live in a very conservative, in some ways, a conservative Midwestern city and county here, and parts of our county are very rural and very similar to a lot of conservative America. But it's a very, what I found is a very pragmatic conservatism. So you can't, you know, don't go and yell at people. Go in and like tell people exactly what you're going to be able to do, and that you're going to show up and do it. And then in fact tell them you've actually been doing it. They just didn't know, maybe. But they respect that more than kind of being, you know, explained to about why they're bad people because they don't want this thing, right? So I think it's possible. I mean, it happened here. I think it can happen there, but you got to get in early, right? And you have to get another piece of legislation that lays it out the way you want to lay it out. We were told we had to do a one-for-one exchange, and we said, no, we're not going to do that. We're doing a distribution model because from a public health perspective, we know that's the most effective way to prevent disease and provide this service. And one-for-one exchange does not do that. And so we were able to get a distribution model off the bat with legalization. So science and rational thought and being nice works.
And
Yeah,
Stuart,
can I
just
add to that? Oh, sorry.
sorry, Kim, I just want to clarify something. So for folks who may not be familiar with a one-to-one exchange, can you just briefly clarify what that means? And then Kim, I'll turn it to you.
Yeah, that was kind of the original way that people were able to do needle exchange and why it was called needle exchange at first, because you had to bring in a dirty needle in order to get a clean one. And that was the only way you could get a clean needle. So if you bought 10 dirty needles, then you could get 10 clean needles. And it's very ineffective and it's not safe. And we just, yeah.
Yeah.
I
But it
don't
did
think
start everywhere, right? Yeah.
are a lot of people required to do one-for-one exchange still? I don't even know.
I hope not. I have two pieces on that though, because that is wicked important. What Stuart's saying, how you do it. It's not just having it, it's how you do it. Because Baltimore definitely went through that metamorphosis of one-on-one and then distributional. And you really want to be at distributional because if someone brings in their friend's needles or they're like, dude, I have a friend who needs needles, like they should just get what they need. But I also want to speaking to the community because I 400% agree. And like 25 years ago, there was this guy in Baltimore. Because, you know, everyone's like, oh, well, now these places are so blue. They weren't blue. So that there's this fellow, Carlos Hardy, who created this process called Common Ground. And it really was what Stuart was talking about, how you go out and speak to different community, you're honest, etc. And so that community piece should not be ignored. And you know, there's always that, it's like a real, we always pretend we are the only ones who know. Well, people are like, I'm concerned about my property value. The property value is already low where I am. I'm trying to sell my house. Like we are disenfranchised anyways. And now you're like, but then those conversations come out. It's like, oh yeah, this is why. And then Baltimore City was able to have they have needle exchange. He did it particularly around methadone programs and people not wanting methadone programs serum. So there are ways to do it and there's documentation often of ways to do it, but I really want to reinforce what Stuart's saying. We're like doing harm reduction. There are science-based and less science-based ways to do harm reduction. So you don't want to implement a program that's not effective, like one-on-one. And then if it's not effective, they're like, see, told you it didn't work. So it is really important to go and talk to other people around those resources.
So there is another question in the chat. And it's from Daniel. Thanks, Daniel, for submitting this, also related to SSPs. So Daniel is wondering how you straddle the line of promoting acceptance and integration within, I assume within primary care, while also keeping the core values and specialization of the work of addiction medicine as a specialty. And Samuel, I'll turn it over to you to respond to this one.
Yeah, Daniel, thanks for that question, because right now I actually do addiction medicine. I also do primary care, and I also train family medicine residents. And the reason I decided on this model was that I realized that my entry point into the community will be more effective if I was in a medical point and not just behavioral health, right? So what I do, and I don't know if this is what you're asking, but what I try to do is I triage patients that I receive, which is I've gone out in the community. Everyone knows I do addiction, but they also know I do primary care. So when I have really sick patients who have a substance use problem, I see them as their primary care because I know they cannot afford another specialty visit, right? And I know it kind of blurs the line a little bit, and it means that your reimbursement might be stuck since you're just in primary care. But at the end of the day, it's a need in the community, right? And there would always be patients who are solely addiction patients that you would see as a specialist. And for me, I think the lines are always going to be blurred, but because of how much important the work we do in this service line, you need some primary care. That is just it. Like, you need some primary care. Be it Hep C, HIV, PrEP. Those are all things that would be awesome if you could do it in one single swoop rather than another referral.
We got to be really careful with that question, because addiction medicine is a wicked recent thing to come about, and people were able to practice harm reduction, as you know, Stuart and my gray hair, for long before addiction medicine was actually a boarded endeavor. And so it doesn't have to be either or. You don't say the primary care doc can't take care of diabetes because there's an endocrinology board. You say absolutely, the primary care physician can take care of the whole person, and when they're out of their depth, they need to talk to a specialist. If we start segmenting things, it is the patient who is going to be screwed, right? And so I think we need to be really careful, even in the way we frame the question. Specialists don't mean that's the only place you go. And it also means all of the specialists, cardiovascular, all the endocrinologists need to understand harm reduction too, because a lot of people don't go to primary care, right? And so I just want us to be really careful when we're talking about holistic medicine, but we chop people up into the different diseases they have. They're the only ones who lose. And they're the very ones who we don't want to have lose in an ideal system, right? They're the ones who are supposed to be getting well. And it's really important. Like, again, addiction medicine is new, and people were getting addiction medicine. And so everyone needs to be taught how to provide these services in a way that is effective and leads to equitable outcomes. And if they're not, if they're out of their depth, go to the specialist. If they're not doing it, they need to be retaught, or they need to seriously be regrouped, maybe regrouped out of seeing patients. But that dichotomy scares me in the question.
Thank you both. So I'm going to try and squeeze in one more quick question. And Kate, if it's okay, I'd like to direct this to you because I know you do a lot of education around harm reduction. An attendee says that they're an ethics consultant for a large hospital system, and they'd like to integrate harm reduction strategies into their recommendations when they receive a consult from a hospitalist or a specialist, particularly cardiovascular clinicians. Do you have any advice for modeling harm reduction rather than calling people out for addiction, bias, and stigma?
Yeah, I think the first thing I think of with this question is just that these are evidence-based approaches and practices. And so rather than calling someone out, like, why are you not doing this? I think the thing to do would be to bring these practices into the conversation. And I think as formal as you can make it, if you have a discharge protocol that includes, referring someone for resources, if they are there with endocarditis, making sure they are connected with a syringe service program or some similar resources. I think as much as you can just integrate it, it is evidence-based, and just make it part of the discharge protocol so that the person every single time isn't having to necessarily think about it. I think Stuart was speaking to this too, like, rather than adding something more for someone to think about, just add this to the checklist for nursing, for the discharging provider, wherever this is going to be integrated, depending on where you want to start, so that people can it's just part of their practice and they begin to know the resources in the community. I think that's another big piece of it. A place where I see a lot of people struggle is they want to help, and they feel terrible that they don't know where to send someone. And so they don't even want to broach the subject of substance use or treatment because they're like, I don't know what to do for this person. And so as much as you can give someone those resources, it actually makes them feel like better about what they're doing for the person. They want to help them holistically. And it can be scary if you if you just don't know how. So that familiarity, I think, with local outpatient resources is really big too.
Thank you so much. So we are just at time. I want to give Kima, Stuart, Samuel, and Kate a big virtual round of applause. It was really a tremendous conversation. And as Kima said, there were so many tidbits. Like, encourage you all to go back and listen to the recording for the great advice from today's speakers. Really quickly, before we wrap up, please stay tuned for the brief that's coming out of the environmental scan that we did on sustaining harm reduction in healthcare facilities. Our presenters also shared a number of resources on harm reduction that we'll be compiling along with those that we shared in the chat and sharing them out with you all after today's event. And lastly, there will be an evaluation that will pop up on your screen. Please take a moment to complete that so we know how to improve our work. Thank you all for being here, for your thoughtful questions. Again, to our panelists and to our colleagues at Vital Strategies, I hope everyone has a great rest of your day, and we'll talk to you soon. Thank you.